For my clinical presentation, I chose metastatic melanoma, and in this presentation, I'll go over how melanoma normally presents itself, how it progresses, and how it's treated. Melanoma is the fifth most common cancer in the United States, and it was estimated in 2018 that there were 91,270 new diagnoses and 9,320 deaths. There are a lot more diagnoses nowadays than there have been in the past, and this might be due to more reporting or more UV exposure, such as in tanning beds. The median age of diagnosis is 61, so this happens often later in life, and it's more diagnosed in men than in women. It can occur in all ethnic groups and can arise without substantial UV radiation. However, there are certain risk factors that put you at a higher risk of developing melanoma, such as having fair skin that will sunburn easily, history of sunburn, having red or blonde hair, because people with red or blonde hair typically have fairer skin and freckle more, having a family history of melanoma, including genetic mutations, being diagnosed with a prior melanoma, and having atypical moles, or what they call dysplastic nevi. Our patient was Tom Schaefer, who was a fair-skinned white male with blonde hair. He was diagnosed previously with a melanoma at age 59, and at age 62, he came into his dermatologist again for more testing for a possible return of melanoma. Before I go more into the diagnosis, staging, etc. of melanoma, briefly go over what melanoma is. So as you can probably tell from its name, melanoma arises from melanocytes, which are these cells in the basement membrane of the epidermis. When there's UV exposure or DNA damage to the melanocytes, they can start to grow out of control like you see in this figure here, and they can cause the pigment to spread across the skin, or the melanocytes grow farther down into deeper tissues in the dermis. It's really important to catch melanoma early, because if you catch it early, it likely won't have penetrated as quickly, and the more penetration there is, the more likely for metastasis there is. So it's really important to catch it early. There aren't a lot of symptoms for melanoma other than that spot or the lesion that you will see on your skin. And there are certain characteristics of this lesion that you should be wary of to see a doctor if you notice these things. So they call it A, B, C, D, E. A for asymmetry, B for border, C for color, D for diameter, E evolving. So basically, if you have this big mole-like thing on your skin and it's really asymmetrical, very noticeably asymmetrical, the border is very indistinct. The color might be varying in different areas of it, so it might be darker in one area than another, or it might be red in one area. It will be significantly larger than a normal mole, so they'll define that as greater than 1/4 of an inch or 6 millimeters. It will also evolve over time. So it might grow, it might change in color, different things like that. So at age 59, Tom Schaefer first noticed an oval brown lesion on his temple that evolved over the next 6 months in contour and border. So what made him see the dermatologist was that it was evolving and changing. Again, at 62, Tom's physician noticed new subcutaneous nodules on his upper back and deltoid. Since they were subcutaneous, they would have been a lot harder to notice, but since he had had a prior melanoma, the dermatologist would have been on the lookout for this. Diagnosis of melanoma, after they look for these concerning features and kind of say, okay, this is pretty concerning, they will group it into one of these 4 different melanoma skin types. The first is called superficial spreading melanoma, which is the most common, and it's diagnosed in 70% of people with melanoma. It spreads pretty far over the skin before it penetrates into deeper tissues. Lentigo melanoma is this one right here, typically diagnosed in the elderly on areas with high UV exposure. There's also acral litiginous melanoma. Acral refers to the extremity, so here it's under the nail, so it would be either on the hands, fingers, soles of the feet, etc. Finally, there's nodule melanoma, which is this hard raised bump on the skin. It's pretty circular here, but it's very high and hard. Tom Schaefer's initial lesion was a lentigo maligna melanoma, like this here, and it was on his temple. 3 years later, he had 2 subcutaneous nodule lesions, so they were probably something like this but they wouldn't have looked exactly like this since they were subcutaneous. When a dermatologist would be diagnosing someone with melanoma, they would also take a family history, including a history of these dysplastic or atypical moles. They would also ask for history of sunburn and UV exposure. They would also do a complete skin exam and evaluate for palpable lymph nodes to see if there was lymph node involvement, which would suggest that the melanoma had spread. They could also do a sentinel lymph node biopsy, which is considered for patients whose melanoma has concerning features. I have this bolded here because Tom Schaefer did undergo this biopsy, which is depicted here on the right. So at the site of the melanoma, they'll inject a radioactive substance with a blue dye, wait about an hour, and see where it goes. So sentinel lymph node basically refers to the first lymph node that the melanoma cells would go if they had spread. So if they detect radioactive substance there, they'll dissect that lymph node out and look for melanoma cells. The lesion would also be removed via excisional biopsy with margins of 1 to 3 millimeters to ensure that the whole melanoma had been removed. And if distant metastasis was suspected, CT scans, MRIs, and PET scans would be performed to see if it had metastasized in distant tissues. Staging happens in two parts. So the first has to do with T-staging, which is based on how thick the melanoma is. So for example, Tom Schaefer's first lesion, when it was removed, was found to be 1.3 millimeters thick, which falls into this T2 category, which is between 1.01 and 2 millimeters. He had no ulceration, so what distinguishes stage 1 and stage 2 is basically A and B, A meaning no ulceration, B meaning ulceration. So Tom Schaefer had this stage 1 melanoma because it had no ulceration, no nodal involvement, and no metastasis. So he was diagnosed with T2A and 0M0 melanoma. However, 3 years later, when his biopsies revealed metastatic melanoma. CT scans revealed metastasis in his lungs, as you can see in these figures here, and in his chest. It's not depicted here, but there were also some in his back and in his trunk. So he was therefore diagnosed with stage 4 melanoma. Treatment for melanoma can vary depending on what stage of melanoma that the individual has. So in localized melanoma, the melanoma itself is just excised and removed, and sometimes they'll do radiation or interferon therapy. Tom Schaefer did not have radiation or interferon therapy, but the lesion was just removed. Management of metastatic melanoma is much more difficult because of how advanced it is. Previously, before there was some new treatments and options, they would use dacarbazine, which is just a chemotherapy, and that is the standard treatment. But as you can see, there's a very low response rate, it's less than 20%, and a very low survival of only 6 months. There's also immunotherapy, which takes advantage of the immune system to attack the melanoma. So they can use interleukin-2 and immune checkpoint inhibitors such as ipilimumab and pembrolizumab to do that. There's also biochemotherapy, which combines chemotherapy and cytokine therapy for a similar result. Tom Schaefer did not opt for this treatment because when they profiled his melanoma, there was a genetic mutation found in it. When there's certain genetic mutations, they're able to do targeted therapies, as you can see here. So certain genes that allow for targeted therapies are BRAF, NRAS, and GNAC. So as I said, Tom Schaefer's biopsy revealed a mutation in BRAF, which is a proto-oncogene, meaning that wild-type BRAF is not an oncogene, but when it's mutated, it can become an oncogene. So he was considered a candidate for a clinical trial combining BRAF inhibitor dabrafenib with MEK inhibitor trametinib. Dabrafenib inhibits mutant BRAF itself to interfere with MEK and MAPK signaling to control cell proliferation. Trametinib interferes with MEK directly to interfere with the signaling pathway to control the cell proliferation. This clinical trial also showed that there was an increased survival by 5.1 months as opposed to 2.7 months. So Tom Schaefer ultimately opted for this clinical trial, and he received 150 milligrams of dabrafenib and 2 milligrams of trametinib daily. After 3 months of treatment, palpable subcutaneous nodules regressed, were very difficult to find, And his pulmonary nodules shrank by over 50%. As you can see here, they're very difficult to even see. After 9 months of treatment, Tom Schafer's disease remains stable, and he continues with the same dosages of medication, and he describes his quality of life as excellent.